I'm Matthew Tolliver, and I'm working as a behavioral health consultant and director of behavioral health in the Department of Pediatrics at East Tennessee State University. So we're in the top northeast corner of Tennessee, in Johnson City, Tennessee. And so I'm working in an academic medical center in like a pediatric residency training clinic here. Do you want to, maybe we can just go around briefly and just introduce yourself and tell us what you're doing and where you are, and then we'll talk a little bit more. Jonathan, do you want to start us off?
Sure. Hello, everybody. Can you guys hear me all right? I'm trying this Bluetooth thing on my laptop for the first time.
We can hear you.
Great. Well, I'm Jonathan Larson. I'm a graduate student at Wichita State University. I work at the KU School of Medicine and Pediatrics, and actually here I'm at Hunter Health Clinic. I'm part of this cancer screening research project. So glad to be here. Yeah,
so glad to have you. Do you want to tell a little bit more about yourself, Rebecca?
I sure can. Hi, everybody. I'm Becca Kolpak. I am a very new faculty psychologist at the University of Rochester Medical Center. I work with Michelle Sminger-Gagne and have wanted to come to these meetings like for as long as she has been, and finally have the schedule that lets me. So that's exciting. And my pediatric stuff right now, literally is so new. I am the new psychologist in peds endocrinology and peds nephrology here at Golisano Children's Hospital. So
great.
It's a lot of things. Thanks. Good to be here.
So are you still a trainee or?
No, I am like very not newly licensed, but like newly have a big girl job.
Congratulations.
Thank you.
I keep a list, and I had you as trainee in my system and postdoctoral fellowship. And it sounded like you were done. So now
I know I am as of like 3 weeks ago. So you're on it, Jackie. Thank you. Oh my goodness. You have a list with me on it. So,
now, yes.
Wow.
Norma. She's washing Mr. Potato Head. So
yes, now it's just Potato Head to be more inclusive.
Oh, that's true.
And like, look, there's like same sex potato families.
Oh, nice.
But anyway, I was going to talk about the baby potato because it's funny. Its diaper is tinfoil. So I was like, man, someone got a little morbid with their humor. But yes, my name is Norma Borrero. I am a pediatric BHC in Austin, Texas at a private practice clinic. So a little bit different. So I see 0 to 18, 19 on a daily basis and clean toys in between. And I'm actually starting my MPH in maternal and child health tomorrow. Like I go to orientation tomorrow. So I'm very excited.
Awesome. Congratulations. And if you haven't been with us much, we're a pretty casual group. So if people need to eat on the call, like please do that. Like it's lunchtime. So totally fine to do that. Let's see. Arissa, do you want to talk a little bit more about yourself?
Yeah, sure. I'm Arissa Wahlberg. I am the managing psychologist for integrated behavioral health for Peace Health's Oregon network. So Peace Health is a hospital healthcare system in Oregon, Washington, and Alaska. So I have all the integrated behavioral health clinicians in the Oregon system. Currently, that's not too many because it's sort of new and we're in transition. But I actually pretty much done onboarding 2 of my BHCs into 2 pediatric clinics. So that's the email I'm going to send out in a little bit, is just looking for kind of CE recommendations for them. Because yeah, they're new to integrated care in general and a little bit new to peds too. So, but that's exciting. So I think that's the most important stuff. I also work, so I'm half clinical time and I'm in the pediatric clinic as well. So it's kind of interesting. We have our 3 pediatric clinics that are now staffed up, but still looking for folks for the family medicine, internal medicine positions.
Oh, and Arissa, I have a great conference for you to send people to.
Awesome. Perfect. Thank you.
Great.
Oh, CFHA? Yeah. I was like, cool. Something I haven't heard about. That's totally on it's totally on the list. I'm like, maybe they could even pull it off this year. So
Yeah,
I
because
will
it's in
be there.
Idaho, right? Do you say in Washington?
So we're in Eugene, Oregon, so it'd
Okay.
be a little bit of a drive. I think it's like
Okay.
6 hours or something. But you know,
Mhm.
easy flight.
Yeah.
Remind me, and after we're done with some preliminary stuff, that could be a good topic for us just to talk about in the group here, in addition to your listserv email. I think that could be a good discussion topic for today too, about the like CE opportunities for new PEDS BHCs.
Cool.
Today we have been, every month we've been having like a certain topic and we've been bringing a bunch of content, but today it's a little bit more like bring your topics, bring your questions. So I think that'd be a great thing to discuss for a little while. Jess, do you want to introduce yourself?
Hi, everybody. I'm Jess Sevick. I'm a pediatric psychologist with Geisinger. I primarily operate in the Northeast. So I was in Scranton, Pennsylvania. They recently relocated me to Mount Pocono, which is just about 40 minutes southeast, which is pretty cool, closer to home for me, which is great. I've been with Geisinger since 2015 when I started my fellowship here. So yeah, and I've been on the CFHA leadership group for the last 3 years. So welcome. If you have any questions about getting more involved in our SIG, just let me know.
Great. Allie?
Good afternoon, everyone. My name is Ali De Gaon. Everyone calls me Ali. I'm in New Jersey and I'm a behavioral health clinician for the Summit Medical Group. And I've been attending these meetings for a couple of months now and have found them so helpful, including all the emails with resources. So, you know, I'm really happy to be here as well.
Thanks. So glad to have you back. David, do you want to introduce yourself?
Yes, thanks, Matt. Hi, I'm Dave Haddock. I'm the CEO of Psychanalytics. I've been CFHA member now going on 4 years. I'm a product developer, specializing in healthcare products for my whole career. And recently, now it's 8 years, got involved with Psychanalytics, and our goal is to streamline and enhance the utility of the PCBH model and basically any other team model for primary care. I think technology has been an afterthought, not to mention being impeded by EHR vendors. And we have a lot to offer to make better use of our resources and hopefully make us able to handle more patients with a limited number of staff that we're going to have for the foreseeable future. Pediatrics is of great interest because that's where the problems begin and that's where we have to focus our attention, but it seems like we're very small part of the solution. So hopefully I've gotten a lot out of this meeting already, and I'm hopeful that we will continue, and I'll see you all in Boise.
Thanks so much. Yeah, you're doing important work, and I think figuring out the ways that we can integrate technology in is so important. Thank you. Noelle?
Hi, I'm Noelle. Sorry, I'm keeping my video off because I'm in a shared space. So I'm trying to not unintentionally have other people in my video.
No problem.
I'm a pediatric psychologist working in primary care at Children's National in DC.
Great.
Yeah. So.
Welcome. Well, thanks for coming. And then I think we have somebody on dialing in through the phone. Do you want to introduce yourself? Yeah.
Hi, can you hear me?
Yes.
Okay, great. My name is Lisa Braverman. I'm a psychologist. I'm a behavioral health consultant in Cincinnati, Ohio, and I work in primary care practices. We have just been given a grant to expand our BHC services into the pediatric offices. So I was delighted to see that you have a group that's sort of talking about how to do this. We're actively researching, how to transition what we do in adult primary care into peds, and we are using Patty Robinson's model, her PCBH model, here at TriHealth.
Great. So glad you joined
No,
us. And oh, go ahead.
I was going to say, I don't know how to unmute myself. So maybe that's something you can do, or I can try when we're done talking.
Can I get your name again, just for attendee list?
Sure. It is Lisa Braverman. It's spelled B as in boy, R-A, V as in Victor, E-R-M-A-N. And I am the lead behavioral health consultant for TriHealth Primary Care.
Great. Thank you.
Great. I think you'll find a lot of folks in the group are either practicing in a PCBH way or familiar with that. And, you know, when I first started, I came to this group and was able to get so many resources. And I think this is a group that's willing to share stuff that they've created and protocols and packets and all sorts of resources, treatment plans. I asked the group one time and I got a ton of treatment plan templates. And so we really try to think about some big questions with, you know, big topics, kind of zoomed out topics within this group, but also not forget just like the practical nuts and bolts. So just how do we help people who even aren't in a director level position, but they're just like a boots on the ground BHC needing to improve their practice all the way up to more like directors of behavioral health level. And you're thinking more about systems and how are we gonna bring everybody together and train them and onboard them and that kind of thing. So that's great. For the folks who have been joining, you kind of know this year we've had the topic around trying to just rally around this pediatric mental health crisis that has been here going on for a while, but that got more publicity when the Surgeon General put out an advisory in December. And so we have the conference coming up in October, and this group, the leadership team from this group is going to be hosting an extended learning opportunity on that Thursday related to a little bit more formal way that we've been thinking about this all year, but how do we address the pediatric mental health crisis in our own clinics, and how do we kind of come together to have a facilitated discussion through that. So if you haven't already, we'd encourage you to sign up for the conference and consider attending that ELO. The agenda for today is Jackie's going to talk a little bit with us about the conference and some opportunities. And I have a list of all of the pediatric focus sessions in the conference that I can send out to you guys in an Excel file in case you're interested in PEDS content if you do come. There's some kind of exciting looking ones, opportunities for that. And then after that, we wanted just to have a little bit of an open discussion. If you've got certain questions that you wanted to post to the group, if you need certain resources, this month is going to be a little bit of like just open access, like let's talk together about what's on your mind. It doesn't have to be related to the pediatric mental health crisis directly. It can be just anything that you're needing some help or advice or that you want to bring to the group. So if you've got job opportunities that you want to advertise, you can put those in the chat. And yeah, take it away, Jackie.
Oh gosh. Well, so as far as opportunities for people in the PEDS SIG, we obviously have the sessions that Robert or Matt had talked about, and then we have some posters too. Which I'm not sure if I sent you that list.
I don't think I have that list, but
send that too. So that's on. So at the conference starts on Thursday morning with the ELOs. Midday starts with the conference, the concurrent sessions on that Thursday. Friday is all day concurrent sessions, discussion groups in the lunchtime, and then Saturday we have concurrent sessions almost the entire day. With we're ending with a plenary session. So we have plenary session Thursday evening, Friday morning, Saturday morning, and Saturday afternoon. We have our Pediatrics SIG special interest group meeting on Saturday at 7 a.m. So that's just a chance for everybody to get together in person. And then just Boise is just a great I don't know if you've been there, but it is just a great little city to have a conference in, like especially our size conference, because we're going to kind of take over. We're using the convention center and then 6 different hotels, but all really, really close to the convention center. And I went up to visit it a couple weeks ago because I'd never been there. And it's just lovely. It's only 4 miles from the airport. So you don't need to rent a car. It's really easy to get downtown. There is a beautiful river walk that you can, like, I think of 25 miles, you could kind of rent bikes or scooters or run or walk along it. The restaurants that I went to were great, and they're, again, all around the area. And then there was a really, really cool Anne Frank human rights memorial. An outdoor, nice big area. It was really beautiful, which I would just encourage everybody who goes to go check it out. And it has a statue of Anne Frank looking through a window, and the tree that you see, if you look through the window, is supposedly taken from the tree that she saw when she looked out her window in Amsterdam. So it was pretty cool. So I am actually really, as much as we're nervous with Idaho with the trigger laws and all that kind of stuff, CFHA made the decision that we can't just cut out cities and states because we don't like their laws, because the work we do is needed there as much as anywhere, So, but it is a pretty cool city with a lot of public art, and it's I would say it's a very blue city in a very red state. So, anything else you want me to touch on, Matt?
No, I think that's good. If you all have questions about the conference or anything, Jackie is our guru of everything conference related. So thank you so much. It's really fun. I've gone multiple years, and it's just a great time to connect with people and network and learn. So we'd encourage you to attend.
Oh yeah, that's another thing we do is that at the opening, so sorry, I forgot one thing. On Thursday, we have an opening reception, and it's an hour long after the plenary session. But halfway through, for people who've never been before, we kind of go off in groups. You don't have to. You can just continue the conversation you're having with someone if you want. But just for people who are new, we have like somebody will hold up a sign that says pediatrics. So, or some, social workers or physicians. So kind of if there were other people you wanted to meet, and that is on the registration form. I asked people, who did you want to meet? And that's how we divide up our groups. And you don't have to do it, but it's just for people who don't know somebody, who want to make sure they meet up with some other people doing pediatric work or social work or whatever, that they have an opportunity to do that. And then on Friday, we have a poster session. That's also a reception. So, and then there's plenty of time to get together with other people for dinners. So I don't know if you guys are planning anything like that, but that's the other thing. So that's it.
Great, thank you. Well, I know Jess wanted to bring up one topic briefly about trainees, but as she's talking, if you guys would put in the chat any questions you wanted to bring to the group, if there are certain topics that you wanted to make sure we cover, or that you wanted to get the group input on, just put those in the chat, and then that'll help us kind of organize our time and make sure everybody's needs are met, and we can kind of plan out the remainder of our time together. Go ahead, Jess.
Yeah, so very brief. Jonathan and I have been working on, Jonathan really doing the legwork of thinking about ways that we can engage our trainee membership in CFHA, so particularly within the SIG group. So if you have, whether they're a member or not yet, if you have a learner that you work with that you think would really like to join you for meetings, if you think they want to become a member, if you're interested in pursuing an organizational membership with your group, and involve learners in that, feel free to reach out to me. Definitely reach out to Jackie. Jonathan is working on drafting an email just to some of our current trainees, kind of a more personalized approach to say, hey, I'm going, we have these meetings every month. You're more than welcome to come, bring your lunch. If you have any questions about being a learner within CFHA, reach out to me. So really just trying to find a way to, engage more of our active membership in these groups and get them involved early on. If you have suggestions for how we can involve learners, please let us know. You're welcome to put it in the chat. You're welcome to shoot me an email or Jackie an email, and we'd be happy to work toward getting those folks involved. Jonathan, is there anything else you would add to that? Because I know you've been looking at those lists and as a learner yourself, right? I know you've shared with me a variety of different opportunities that you've gotten from engaging in the SIG.
Yeah, no, I'm actually going to draft up my personal little bit right now, but no, as just a graduate student, just having this opportunity to be involved in this SIG has been very helpful, especially my program only offers, really not much in the pediatric world. So I think it's just a great opportunity and resource to meet people, learn. Yeah, no, that's about it for me.
Great, thank you both. Arissa, do you want to talk to us a little bit more about what you're going to write in the email that you're going to send out, or would it be helpful? Are there any things that this group could discuss that would help you in what you're looking for or trying to develop?
Yeah, I mean, it's pretty open-ended. I would just love the request from my BHC was CE specific, but I think any kind of like reading or like pre-recorded training or live training opportunities for BHCs who are new to integration. And I would love stuff more specific to working in pediatrics. We're doing mostly PCBH. We might be bringing in some elements of collaborative care, but I feel pretty solid on training them on those general principles of the model and working in medical clinics. So again, more sort of like go-to interventions for peds or like specialty things that can show up in pediatric clinics and getting them trained up on that stuff. I already had them go through the Seattle Children's FAST trainings. So they have that under their belt. And I'm trying to think what else I had them do.
There's a lot. Have you looked at the websites that CFHA has?
Not yet.
Okay, because we do have like a number of resources that are available. And then if the people are members, then they have access to the entire LMS as well.
Right. I'm going to encourage them to be members and then look through that. I did kind of just glance through. So, and I know I've accessed some of the training stuff on the CFHA. So
yeah, and we do have a lot of videos that David Bauman and Bridget Beachy put together on the site also.
Yeah, cool.
So I'm in a pediatric residency training clinic, but I have a doctoral psychology extern every year that I have to, teach behavioral pediatrics content to. And 2 years ago, I worked with a couple other interprofessional faculty, and we developed a behavioral pediatrics course, like a whole 3 credit-hour graduate level course that psychology, psychology, social work, and medical students took. So we developed like a whole curricula for that with kind of every week was a new topic, toileting stuff, anxiety, pill swallowing, whatever, and had, developed cases through that. So what I usually do is use that kind of course content, and then during like the first 6 months of their onboarding period, we incorporate those, like we block some time for them to be able to almost like do a little mini course to get up to speed on that PED specific content. Because I think part of it is the learning the PCBH part, which can be new and a whole lot in itself. And then for our learners, if they're early on in their graduate school, it's like learning just basic clinical skills. And then the third part is now how do you do it with all the PED specific content? And so we wrote an article about it this year that kind of lays out the content of that curricula. And I'd be happy to I have all of this stuff organized in a OneDrive folder. It's like kind of like the key readings by topic and some cases if something like that would be helpful. What I usually do is just kind of assign them like, all right, this week, like, let's focus on toileting. And then I try to route them cases related to that. And this is more of a formal, supervisee relationship, and they're in grad school. But I wonder if you know, you could adapt it in some way where it's like a little mini intensive or something that they do if they had time for it.
That sounds great because yeah, I do plan, we're going to be doing monthly meetings, and I would I'm thinking half the meeting will be like a Skillshare kind of thing where we can go do the specifics of toileting or whatever the topic is for that day. So that would be super helpful.
Yeah, sure. We're also, we have postdocs that we're in pediatric postdocs this year that they have to do, you know, weekly didactics, and we develop content for that. So if there's ever any overlap in those meetings, it'd be cool to even, you know, just Zoom together for some of them, or
Oh yeah,
have our folks Zoom with you and vice versa to do some collaboration on that.
cool. Yeah, ours will be early morning, which means are you on Eastern time? Where are you?
Mm-hmm.
Yeah,
I'm on the Eastern time.
Yeah. So cool. That sounds doable.
Yeah.
Thanks.
You're on Eastern too, or no?
Oregon. So it's
right.
it's 9:30 right now.
Yes. Okay.
So my 7:30 a.m. would would be 10:30 for you guys. So.
Gotcha.
Yeah.
Well, if you want to put your email in the chat, I could send you at least some of the stuff that we like, a few things that could work. But
yeah.
Does anybody else have stuff that, like, how do you go about training people in the PEDS part of PEDS PCBH?
I put a couple links in. I'm trying to find a webinar that myself and Dr. Meadows actually did with APA a couple years ago on pediatric integrated behavioral health. It was actually designed to be given to graduate students as an introduction to IBH and like some things that we do that are pretty unique in pediatrics, like toileting and sleep and that kind of stuff. So I'm trying to find that link. I'll add it into the chat if I can find it. I also put in the MHTT, so the MChat network. So there's some colleagues out of Monroe Meyer Institute who have done, and others across the country that have put together through grant funding some really awesome, like, how do you get IBH off the ground? Most of those folks are pediatric focused. So I put that link in there as a PDF. It's like a little manual. I also put the Dream IPC conference is actually through Nemours Health System. It's in Delaware. They put on a conference every 2 years that is pediatric integrated behavioral health focused, and they do a fantastic job. And there's a lot of crossover between our group here at CFHA as well as like APA Division 54 and others that present at that conference on pediatric specific topics.
Cool, thank you. I did my internship at
in
Monroe Meyer, so.
Oh, there you go. Yeah, so those folks, I thought your name was familiar.
Yeah.
So those guys, they're, you know, they recently launched a big handbook about this as well. I'm going to try to find the webinar that Tanya and I put together on pediatric integrated care, and if I can find it, I'll send it to you.
Awesome, thanks so much.
Hi, this is Lisa. Because I phoned in, I don't have access to the chat box, but you're talking about such wonderful content. Would it be possible for you to email me those links instead?
Sure. Yeah. What we can do is, what we usually do after the meeting is we send an email out to everybody, just kind of summarizing like, hey, here were the resources that we discussed within the call. And as long as, Jackie, do you have the list of everybody that's attending here by email or no?
I do, and I keep that every month, so I do, and I'll send that to you guys. And you know what, I can probably make a list. Who's taking the minutes?
Well, I think nobody really today because Michelle is out. So,
okay. So
I'm
then
trying to facilitate / take some notes, but I'm probably
okay. So are you copying the stuff in the chat, or do you want me to do that?
If you're able to, that could be
certainly
helpful.
can.
Yeah.
I can do that.
I usually save all these chats and file them away, so I'd be happy to share it.
Oh, and I can do it too, but thank you very much. But I can easily do it on my end too, and then you'll have it twice. But then I'll send it out with the list to the co-chairs.
Yeah, I
it's-
think Monroe Meyer, like you guys were saying, had developed a whole like module-based pediatric specific sequence as well for their postdocs and trainees. We were collaborating with them on a grant a while back, and I think they have some really good stuff. We also have some like past ELOs from this group has put on for the conferences have been like this year. It's pretty kind of this broad, peds mental health crisis topic, but in the past they've been very content specific, like here's how we help with sleep, here's how we help with externalizing behavior problems. And so I can try to send the links to some of that material potentially too.
That would be wonderful. I feel like I've missed so much by not participating in this group for as long as it's been going on. So it would be great to just sort of have a full understanding of the things you're talking about.
Sure.
Hey, Matt, this conversation raises a question in my mind. Pediatrics covers such a huge range of developmental ages. And we've been talking about toileting and sleeping like for the younger ages. I'm more concerned about the early teen years and the suicidality that's prevalent these days. And now I've heard that gets down to as early as 8 and 10 years old. Kids are thinking about suicide. I'm just wondering if the people in this meeting today are kind of biased towards one end of the age spectrum or the other.
Yeah, what age range do folks serve? Mine's from birth to about 21.
Yeah.
0 to 18.
Okay, so there's no real bias towards either end of the age range. Okay.
It's whatever presents, right? We're here to help. And same thing, even with like, I'm finding, kind of along with the suicidality piece in our teenagers, especially amidst the pandemic, some sleep disorders being more prevalent among our teenagers as well. So all of that stuff that we do when we're doing anticipatory guidance with our littles and new parents, I'm finding I'm doing a lot of it with our teenagers too, especially with going virtual schooling and not necessarily having a specific schedule and things like that. A lot of the late sleep phase disorder I've been treating in primary care among our teenage group. And you're exactly right. I think I'm doing safety planning with just about everybody at this point over the age of 7 or 8 because of just the high prevalence of concern and traumatic stressors in our communities. So
the other topic that concerns me, especially for girls, is the effect of social media on their self-worth and self-image and where that leads them into a very dark place.
Yeah, and the pandemic, I think, compounding all of that, right? And just like people are more isolated and probably more, I think it's better now that kids are back in school, but I think it was where like social media was kind of the only social connection for teenagers for a while there.
And I think body image is really just like a lifelong issue. And for women, especially, because it's just, especially in America, right? So much of worth is related to what your physical appearance is. And I think in the recent years, that's changed more. Like Target now has like full figured models, right? And like the mannequins, we see more different bodies, right? Different skin tones and advertising and things. We also have more like media, even, Disney, like with Moana, like people aren't like going for princes anymore. So I think that's helpful, but I think it's just going to be a forever issue. And to just say kind of like when I have my teen girls who, are having issues with this, I focus on like the functionality of their body, right? Having like healthy comparison to people who like don't have limbs and like start following people on Instagram who are more inspirational in terms of showing like this is what I look like on Instagram. This is also my body. I've seen that trend too. Like this is a fit body and this is a fit body where they're showing like their cellulite and if they're not holding in their stomach. So that to me, that's just like, it's going to be a lifelong issue because media will constantly show, and even with boys too, right? With abs and everything, right? And the superheroes, because I've had boys too who feel bad about their bodies because they don't look like Chris Hemsworth. So it's just like, well, only Chris Hemsworth looks like Chris Hemsworth. So anyway.
Yeah, that's a good point. How are people addressing eating disorders in primary care or in your setting that you're in? And how do you have a certain threshold for what you kind of treat in your setting versus connecting to others? We don't have great intensive help for kids with eating disorder in our area. We're pretty rural and people have to travel a really long way, but I kind of wondered what other how you handle it or treat it. It's something that's exploded during the pandemic. The admission rate for eating disorders and at least they were presenting in EDs has gone up a lot, but is it something that's coming up in your all's practice?
It's something that's definitely coming up in our practice here. We don't necessarily treat eating disorders, so we refer out, but a lot of it, it's out of network providers. It comes at a big cost to the families, which, you know, many times it's so difficult and challenging to connect them somewhere where it's not going to be so expensive, or someone that really specializes in it. There's this site, and I know this was random, but this was issues to like utilize interventions just to help with either perfectionism, body image issues, and they just have like modules, and it's really helpful. And I found that beneficial in working with my teens that have body image issues. But I noticed that media is also helping with that, like what Norma said about talk. It's just, you know, so many things are changing for the better. I see it's at a slow rate, but for the better. So I'm sorry if that was like a little bit all over the place with the eating disorders, but it triggered like so many thoughts.
No, that's helpful. If you can find that website, maybe put it in the chat and then folks can access that as well. What other stuff has come up for you all in terms of either questions you have or topics that you'd like to put to the group, or maybe it's something that you feel like your organization is doing really well that you just want to kind of share to, you know, disseminate that practice or that idea more broadly?
I don't know if we're doing this well. So I think I'm one of the only like pure, just like clinicians here. I want to join the psychology club one day. I'm going to try applying to doctoral programs again. So I would love advice on that, because I'm just like, how do I get shinier? I'm trying so dang hard, but I know they only take like 5 people. Anyway, I feel like we're kind of, I'm just like inundated, just like swamped with kiddos, and like they thought the summer would be slow. No, I was seeing like 135 patients a month. It was just, I'm already like, I do have some appointment slots. I'm already booked through September. I asked to have my October open today. So I feel like I'm just kind of like hanging on like a little kitten, and really like want to move to like a 4-day work week because I'm tired. I mean, I just don't know, and I guess this is everyone, like I just don't know when it's gonna like stop, like when there's gonna be like a kind of evening out, because you know, and I'm sure you saw this too, like with like school out, everyone was like, we're better, and then like school coming back, anxiety, and now in school after the first week had our first week here. So now I'm getting my kids back, be like, first week was great. No, it wasn't. And
we still have ADHD and now we need help figuring out how to deal with it.
yes. So I guess that's one thing I'm trying to make an ADHD skills group that will launch next month. I had like a mini pilot a month ago and learned a lot from that. And so that's my answer. Like, I'm trying to make groups. I'm trying to make an anxiety group. And also my other love is like perinatal. So I'm trying to make like a perinatal group. So I don't know, for like my solution, right, for the wave is to make groups. I don't know. I'll just try to catch more people at once, but I don't know what other people are doing to try to not drown.
Well, we've done that here at Geisinger. When we know that there's like, especially during the busy seasons, right? And we're getting a lot of the same presenting concerns. So like we run a disruptive behavior clinic group, right? Where we're teaching, like, it's like 7 sessions where we're teaching parent management tools. We've done that virtually since the pandemic. We were piloting our anxiety groups again here at Geisinger. Some folks have done like a gender group, which is a little trickier to do virtually sometimes. So that's been our when we know, right, we're going into the busy season and we're getting a lot of the same type of referrals, like trying to put that group together, not only to provide them high quality care in a shorter period of time because you can see more kids at once, but also to allow like the caregivers to get support as well, which has been helpful. I don't know if you have this infrastructure where you said you were private practice primary care, but if you have other colleagues that are also doing this work in your setting, you know, sometimes like I may not have the infrastructure or the volume, let's say, to support a group, but if I know that one of my colleagues in another clinic is within our system, then we might do like a regional group, right? So if they're able to get on virtually, we funnel those kids there. I've also been trying really hard to build up community partnerships for longitudinal care, as well as within system care. So like really being firm, like this is our model. Of course, being flexible. So kind of like Jello, firm but flexible. In that, you know, yeah, right. I feel a little wiggly sometimes, a little shaky. I'm having Hotel Transylvania like images pop through my head here, but you know, trying to say, hey, we do 5 to 7 sessions. We hit the ground running with skills, right? We're really going to be skills focused. If you're looking for something different, something more, something outside the hours that I work, let's like bridge that care, but let's really work actively at getting you support. So sometimes that means reaching out to case management, either within our system or encouraging the family to reach out to a case management provider within their insurance company to help get them linked with a longitudinal provider, and really thinking about like a stepwise care approach versus the I'm going to do everything approach. There are times where you have to do that, right? But I think the more where you can triage, right, and get kids where they need, the better. I understand that's easier said than done in the climate that we have. So just some ideas.
No, that's great. Thank you. I've been looking for like case management things and I was like, oh, I forgot that you can do that through insurance. So yay, thank you. Yeah, there are other people in the group, but they're at a different location and they have psych interns. So they're kind of like busy with that. So I'm in my little group too. There's only 3 of us. I'm just the pure clinical. So I think that's why I'm so busier because my schedule doesn't divide into like training too. No, but this is great. And the community partnerships, yes, I've been thinking about that. And this is better, well, not better, but this is like good to hear to push me to keep doing that. What I hear a lot from my patients and parents is that there's like a 6 to 8 week wait list for most providers. And then also, because we have UT Austin here and they have the Texas Child Study Center, where Jeff Shahidullah, right? And they have a 6 to 8 month wait list. So I'm like bridging care, but yeah, I'm trying to figure out like who, because Austin, bless it, doesn't really have, it's like a weird mix because it's like a very affluent population, but there's still like enough, you know, Medicaid patients that need help. And there's only kind of like one system that really sees them. So it's kind of weird. But yes, thank you.
And Norma, I think seeing all of those patients demonstrates like the need in your community for behavioral health services, but also I think speaks to you a little bit that people come back, right? And that, you're doing a good job probably, right? And that you
Gotta
have
put that on my
people and
doc application. They come back to see me.
yeah, that's a big deal. But it also makes me, anytime people are doing the kitten hanging, makes me think about like, how do we support each other and how do we prevent burnout, in the jobs that we do? And, if you feel like you're, overwhelmed, I mean, I think we've all been there in a certain time, but if you are all clinical and you don't have a lot of breaks or admin time, or it's hard to sustain that kind of without any time to catch up. And so I wonder maybe if we could kind of throw that out to the group a little bit of just how if other people have advice or just how they have navigated a similar situation, like how do you do what Norma's doing but not get burnt out, right? Because that can be hard.
Norma, do you have any protected like admin time, or are you like 8 to 5 seeing patients? 8 to 6 or whatever.
Yeah. So the thing is, because I'm doing my MPH, then I don't like the way the admin people, the higher ups said was that I don't get pure admin time because I'm taking time to take classes. So I have like an admin morning. So I get 4 hours to like go to a class and then I have to come back. So, I mean, I guess I could talk to them about this, but then I worry about like salary cut, and Austin is like stupid expensive. So, yeah, but yes, eventually I would love to have like a pure admin day. Even if I had to do like 10-hour days, then I could have like my one day.
Well, that seems crazy. You have to choose between professional development and doing your job.
So it's something that I advocated pretty strongly for my group, is making sure there's protected admin time. I got the initial pushback on that, and was able to, I think, make a pretty good case for having it because of burnout. Think about like pathways or groups or like other things that can really more meaning in your work. So just wanted to check in about that, because they often see just numbers, right? But if we can say, look, like we've actually, and I put this out to the listserv to get other people's kind of backing on it when I was exploring this, and somebody, and now I can drum up that email, but said we've actually shown that they see the same number of patients that they did when they were full-time, but they're happier and they're staying longer. And I don't know that anybody had any hard data on it, but that was their experience. And across the board, overwhelming, everybody was like, you need to have protected time for your employees. So
I think they published a lot on that and have a lot of statistics for their practice.
That's where I came from. So I worked with them for the last 5 years, and then started this at Peace Health. So yeah, I knew, and that was the model that we had, and I saw that time.
They've done a great service in publishing data.
Yeah.
Everybody wants data.
Yeah.
I have a couple of questions. Are you seeing any support coming your way from community health workers or peer counselors? It seems like more of an adult thing these days, but I'm wondering if it's getting into pediatrics at all.
We're just about to start somebody in our clinic like that through our local hospital. Actually is embedding somebody in, and it's going to be more of like a resource management role rather than a clinical role. But we, in our practice, we have social work students, grad students who rotate through, who are kind of this resource team. So whenever the BHC sees a patient, like all of the social determinants of health stuff and the referrals and the resource stuff can kind of be carved out to have that person address that with the BHC to kind of free that case management or research management, have a designated person for that. And so the BHC is not having to do like 4 hours of that work at the end of the day, because it piles up a lot of times, I think. And it's a really needed service, but we have the social workers, but we're about to start with the community health workers. Were you going to say something, Marissa, too?
Yeah, we have just for our pediatric group. So again, 3 pediatric clinics. We have a care management team. So we have an RN care manager, and we brought on a social work care manager about just over less than a year ago. So the social work care manager takes on a lot of that resource piece of it. Although we've continued to have to kind of figure out when kiddos are needing more traditional outpatient mental health, whose bucket is that in. But she does a lot around like communicating with DHS cases and, helping with housing and all that kinds of stuff. And so that's been helpful. And then we've had conversations around, we still need more. So thinking about bringing on a community health worker to do some of that other stuff, as well as I would love to have like a, BHC assistant, sort of like an MA sort of role for BHC. So yeah, we're hoping to do more. And it is a half day for full-time BHCs. So 4 hours for 1.0 of a protected admin time. But our BHCs, I really strongly help them draw that line of, I am not your resource coordinator. I'm not going to be making lots of calls to the schools or that kind of stuff. So they are really, when they're seeing patients, that's what they're doing. And then they do their notes, and that's kind of the end of their responsibilities.
Yeah. We're like, that would be really nice.
It's not easy for them either, because the 2 that I just onboarded, they're in this interesting, they were called BHCs, they're LCSWs, so they naturally gravitate towards doing that stuff. So we've had to do a lot of like shifting and readjusting kind of thing. So it's a work in progress, but I think they're really appreciating. They're like, so that's not my call to make, right? Like, right, exactly. Here's the person who can do that for you. Yeah.
I think that's really important, and yeah, like helping everybody work to the top of their license and ability. And I think that helps mitigate burnout too, if you feel like you're able to, do your part and make a difference, but then not have hours and hours of all of this other work that gets built up that you feel like you have to do in order to, help the patient. And in our clinic, it's we kind of wax and wane with the amount of trainees that we have. So we'll get several trainees, and then the clinic will get accustomed to a certain level of service kind of for patients, and a certain amount of how far we go to coordinate care and all of that. And then if we lose that, then we have to adjust everybody's expectations for how much we call schools and sit on an IEP call or something like that. So yeah. Anything else? Any final thoughts before we go for today?
Yeah, I just want to put a plug in for a book called Drive. The surprising truth about what motivates us. The author is Daniel Pink, and he looks at 3 specific areas that everybody can work on: mastery, purpose, and autonomy. And purpose is not hard for healthcare workers to come by. Mastery is defined as the system, the clinic, the process helping you become better, more professionally capable. But the one that kills everybody is autonomy. There's just not enough autonomy in the system. So you're never feeling self-directed, you're always feeling oppressed. And so it's a really interesting read. It's not long. And various other CEOs and healthcare companies I know are making sure that their people look at this book. So I would encourage you. Mastery, purpose, and autonomy. If you can cover those three things, the chances of burnout are far, far less.
Thank you. Wise words to end on.
I'll put that in the chat. Sorry.
Yeah, put it in the chat. That'd be great. Well, it was so good to see everybody today and great discussion. And we will try to send out an email that summarizes some of the resources that we talked about. And feel free to email me if I'll put my email in the chat here. And if you don't get a resource that you wanted to get, just let me know and we'll make sure we get that to you. We will meet again next month and at the same time and same place. And I think we're going to talk a little bit more about how to navigate cultural differences with our patients, with our providers, BHC, and how do we do that best. But I hope you all have a great week and hopefully we'll see you at the conference too.
I hope that topic includes how to engage parents.
Yes, I think I'll have to go back and look at all our notes, but I think it does.
Great.
All right, see you all later.
Good. Thank you.
Bye.
Thank you.
Thanks.